The worldwide incidence and prevalence of kidney disease is very high and encompasses these variations. One is chronic kidney disease, known as CKD, which has 5 stages from mild disease to kidney failure. One is end-stage renal disease, which is actually stage 5 of CKD, and this for treatment needs either dialysis continually or a transplant. And the other is AKI, or acute kidney injury. Stage 3 kidney disease is the most commonly seen. And older adults, as well as other individuals with CKD, are vulnerable to acute kidney injury secondary to drug-induced kidney injury or critical illness. The kidneys play essential roles in maintaining homeostasis. The loss of nephrons is generally compensated by hypertrophy and increased activity of the nephrons that remain. The kidneys regulate the volume of water in the body, as well as the composition of body fluids. A prominent role for the kidney is to help maintain fluid balance by varying urine output. The kidney excretes nitrogen waste and acid generated by protein metabolism. It helps to regulate the blood pH through the handling of hydrogen ions and bicarbonate ions during the urine production. There are various metabolic waste products that include creatinine, uric acid, conjugated bilirubin, conjugated steroid hormones, and sulfuric acid. In the kidneys, vitamin D is converted to its biologically active form, calcitrol, which is an important hormone regulator of bone remodeling and calcium absorption in the small intestines. The kidneys are also the primary regulator of red blood cell production through erythropoiesis, and they secrete the enzyme renin. The renin-angiotensin-aldosterone system, or RAS as it is known, plays a key role in blood pressure and blood volume regulation. Water is a solvent and transports nutrients, waste products, blood gases, electrolytes, hormones, and other various solutes throughout the body. It serves as a lubricant, reducing the friction between adjacent tissues, organs, and in the joints. It also accounts for over half the total body mass of most adults. We know as nurses that women tend to have less muscle mass and more adipose tissue than men. So the average woman has less total body weight than the average man. The water and solutes actually make up 55 to 60% of the body weight in the adult. The aqueous compartments are made of extracellular fluids, which is plasma and interstitial fluid, and intracellular fluid. Extracellular fluid moves between the plasma and the interstitial space by filtration and reabsorption across the capillary membrane and via the lymphatic system. The movement of water between the intracellular and the extracellular compartments involves osmosis across the cell plasma membranes. Intracellular fluids have a high concentration of potassium and magnesium, while extracellular fluids are high in sodium and chloride. The kidneys are bilateral bean-shaped organs positioned in the retroperitoneal space against the posterior wall of the abdominal cavity on either side of the vertebral column. The renal hilum opens into the renal sinus and is the site where the renal artery, veins, ureter, nerves, and lymphatics enter and leave the kidney. The urine drains out of the pelvis of the kidney to the ureter. The renal calyces and pelvis occupy the innermost region of the kidney, the renal sinus. Each nephron consists of two main parts, the glomerulus and the renal tubule. Nephrons are classified as either cortical or juxtamedullary. The cortical nephrons, which are the predominant nephron type, have glomeruli located in the outer cortex and have a relatively short loop of Henle. The juxtamedullary nephrons have glomeruli located near the cortico-medullary junction and have long loops of Henle that dig deep into the medulla. Each nephron is supplied by an afferent arteriole that gives rise to the glomerular capillary cluster, ending in an efferent arteriole, then to the peritubular arteries. The glomerular capillaries are the site of filtration, which is the movement of water and solutes out of the vascular space and into Bowman's capsule. The peritubular capillaries are the site of reabsorption of water and solutes that are transported across the tubular epithelium to the interstitial space, followed by a bulk flow into the capillaries. The vasa recta are specialized peritubular capillaries of juxtamedullary nephrons. The glomerular capillary loops are the major functional components of the glomerulus. These are surrounded by mesangial cells and Bowman's space. As the glomerular filtrate forms, the pressure in Bowman's space rises. This pushes the filtrate into the proximal tubule and down the remaining nephron tubule. At the junction of the afferent and efferent arterioles, the thick ascending limb of the nephron passes between the two vessels, forming the juxtaglomerular apparatus, or the JGA. The JGA cells monitor the nephron processing of the filtrate and initiate homeostatic adjustments. Here, a cross-section through a capillary loop shows the glomerular capillary filtration barrier that is composed of endothelial cell, basement membrane, and the foot process of adjacent podocyte cells. The mesangial cells provide the supporting structure for the capillaries and the podocytes. Filtration in the glomerulus is similar to the systemic capillaries. It occurs because the interaction of the hydrostatic and colloid osmotic pressures across the capillary wall favors an outward movement of the fluid. The net filtration pressure represents the difference between Starling forces promoting fluid filtration and those promoting fluid reabsorption. The net filtration pressure in the glomerular capillaries is dominated by high capillary hydrostatic pressure, and this is due to the resistance posed by the efferent arteriole, as shown by the purple arrows. Opposing the capillary hydrostatic pressure is the oncotic pressure, which rises along the capillaries due to the filtration of water and solutes that concentrate the proteins within the vessel. These are the tan inward arrows. The capsular hydrostatic pressure also opposes filtration, shown as the blue inward arrows, but in addition provides a driving force for the fluid moving down the nephron. The hydrostatic pressure changes in the renal vessels affect the two capillary beds. The first is the glomerular capillary bed, which has higher than normal capillary hydrostatic pressure and promotes the production of the glomerular filtrate that enters the nephron tubule. The peritubular capillaries have lower than normal hydrostatic pressure. These aid in the reabsorption of more than 99% of the glomerular filtrate. The remaining tubular fluid is excreted as urine. This is an overview of the nephron processes. After filtration, which is number 1 on the image, any solute, be it ion or molecule, entering the nephron can follow one of 3 paths. The solute may be reabsorbed by tubule cells and pass into the peritubular capillary blood, leaving the urine space and returning to the circulation. Excuse me. This is true for filtered glucose. As an example, in number 2, the filtration occurs at the glomerulus, where about 10% of the renal blood flow enters the tubular space. The solute may be enriched in the urine space by transporters secreting additional molecules from the peritubular blood across the tubular cell layer and into the lumen. This is true for many of the antibiotics, and this would be shown in step 3. More than 99% of filtered water, electrolytes, and small molecules like glucose and amino acids is reabsorbed by the tubules and the peritubular capillaries. The solute may remain in the tubule with its absolute amount unchanged by reabsorption or secretion until it is excreted in the urine, which would be number 4. The wastes that are secreted from the peritubular capillary blood into the tubule are for the excretion of urine. Creatinine is a waste product that is produced as a breakdown product of the high-energy compound creatinine phosphate during muscle metabolism. The renal clearance for creatinine is essentially determined by the glomerular filtration rate. When the GFR decreases because of acute or chronic kidney dysfunction, The creatinine will build up in the blood despite a compensatory increase in renal tubular creatinine secretion. Serum creatinine levels are routinely used to estimate GFR using equations that account for age, sex, body size, as well as ethnic descent. Measured or estimated GFR, known as small e GFR, is the primary indicator of kidney function in health and disease. A reduction in the glomerular filtration rate will delay any drug clearance and could in turn result in toxic level buildup that would be greater than the normal dose of medication. This is especially vital for the CNS to think about whenever they are looking at elderly individuals. Clearance is defined as the volume of blood plasma that is cleared of a certain solute in any specific period of time, which is routinely 1 minute. So glucose is freely filtered, but at normal plasma concentrations, it is completely reabsorbed by tubular transporters, giving it a renal clearance of 0. Permeability, blood flow, and capillary hydrostatic pressures are higher in the glomerular capillaries than other organ beds. These factors combine to make the glomeruli very vulnerable to damage from vascular sources. The acute presentation of glomerular disorders may include proteinuria, hematuria, oliguria, blood urea, and creatinine elevations, as well as hypertension and edema. Autoantibodies and antigen-antibody complexes are able to leave the glomerular capillaries and bind to targets in the basement membrane or on podocytes, precipitating immune-mediated kidney injury. Antibodies and antigen-antibody complexes can be deposited within the glomerular filtration barrier. This would impede the filtration rate. Other systemic disorders that may damage the kidney through glomerular antibody deposits include systemic lupus erythematosus, scleroderma, and multiple myeloma. These are the targets and pathways of immune-mediated glomerular damage. Preformed immune complexes can be filtered and deposited in the mesangium, promoting the local inflammatory response. Here, the antibodies are shown as black Y-shaped structures, and the antigens are the pink circles. The antigens may first deposit in the mesangium, where the circulating antibodies will then bind to initiate the inflammatory response. Endogenous substances recognized as antigens, shown as triangles, can be located on the glomerular capillary cells, which are tan. The basement membrane, which is purple, the podocytes, which is blue, or the mesangial cells, which are green. These attract antibodies to promote the immune response. Glomerular diseases with immune activation can produce minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, acute post-infectious glomerulonephritis, membranoproliferative glomerulonephritis. Also, other diseases are immunoglobulin A nephropathy, dense deposit disease, chronic glomerulonephritis, and various systemic disorders that are also associated with glomerular damage, such as lupus, myeloma, and scleroderma. This image that is being shown is glomerulonephritis that occurred from a disseminated gonococcal infection. The immunofluorescent detects mesangial and glomerular capillary deposits of complement protein C3, which is bright green, in a biopsy specimen. Diabetes is the most common cause of CKD. Manifestations of diabetic neuropathy include progressive decreases in GFR and increase in proteinuria. Hypertension is the second most common cause of CKD, and hypertension also promotes hyperfiltration. GFR is a measure of renal function that is dependent on the renal blood flow, the net filtration pressure, the permeability of the filtration membrane, and the total surface area of the filtration membrane. The regulation of renal blood flow and GFR is accomplished through renal autoregulation. This is a mechanism that is intrinsic to the kidneys. The myogenic mechanism depends on the inherent property of vascular smooth muscle cells to contract in response to stretch. The myogenic mechanism results in vasoconstriction that decreases the blood flow to the glomerulus. This prevents the increase of the glomerular hydrostatic pressure that could have occurred. The kidney's ability to maintain fluid and electrolyte balance is negatively impacted when the renal blood flow and the GFR are extremely high or low. Tubuloglomerular feedback is a negative feedback mechanism that serves to notify the afferent arteriole of downstream alterations in tubular flow that is associated with fluctuations in GFR. This results in alterations of the afferent arterial diameter that leads to adjustments in the glomerular filtration rate. The macula densa responds to changes in tubular flow rates or sodium chloride concentration of the filtrate that flows from the filtrate flowing from the thick ascending limb into the distal tubule as an indicator of glomerular filtration rates. The extrinsic regulation of the renal blood flow and GFR is provided by the endocrine and sympathetic nervous system signals, and it is important in preventing and reversing extreme decreases of systemic blood pressure. Endocrine regulation is provided primarily through the renin-aldosterone-angiotensin system via mechanisms that begin with the juxtaglomerular apparatus. The stimuli that trigger renin release are sympathetic nerve release of norepinephrine. This activates the B1 adrenergic receptors on the JG cells. This reduces blood pressure in the afferent arteriole and stimulated by the activated macula densa cells. When arterial blood pressure drops below the autoregulatory range, which is less than 80 millimeters of mercury, the sympathetic nerves stimulate the vasoconstriction of the afferent arterioles, which then reduces the renal blood flow. This is a short-term compensatory mechanism that decreases the normally abundant renal blood flow to help preserve the flow to the heart and the brain under low pressure or low volume states like hemorrhage or dehydration. The looped structure of the vesica recta preserves the osmotic concentration in the medullary interstitium that is required for concentrating the urine. Hypoxic renal damage causes pre-renal failure, commonly seen in critical illness that involves hypotension and hypovolemia, with hypoxic injury leading to rapid loss of renal function in patients that have sepsis, trauma, MI, or other critical illnesses. A history of acute kidney injury is a risk factor for the later development of CKD. In the image shown, the blood flow to the renal cortex is very high. This perfuses the glomerular capillaries of approximately 1 million nephrons per kidney. The juxtamedullary nephrons represent 15% of all the nephrons, and they have specialized peritubular capillaries called the vasa recta that descend to the inner medulla, then make a U-turn and ascend back to the cortex. The oxygen leaves these capillaries along their length, creating a relatively hypoxia deep in the renal medulla. This creates a vulnerable region that can sustain hypoxic damage during systemic hypotension and hypoxemia.